Dr. Sanket, over to you, sir.
Thank you. Good evening, everyone. I welcome one and all to ProCare AHT's MedLive ECMEs, a scientific platform provided by McLeod's Pharmaceuticals. I am Dr. Sanket Nevale, representing medical affairs at McLeod's. And today we are here to discuss on the topic, bridging the gap in diabetes management with or without CV risk. But before we go ahead, let me introduce my company. McLeod's is equipped with an experience spanning across 3 decades, has emerged as a global force with a dedicated team of around 14,798 professionally qualified employees worldwide and state-of-the-art manufacturing and R&D setup. We are one of the fastest growing pharmaceutical company in India. With a growing presence in more than 80 countries, McLeod's is now gearing to be a pace setter for the world healthcare. Today, I'm proud, and also I would take this opportunity to introduce our speaker, our moderator for the evening, Professor Dr. Subhankar Chowdhury, sir. Sir is a professor and head of Department of Endocrinology, IPGMENR, and SSKM Hospital at Calcutta. He is the editor-in-chief, Indian Journal of Endocrinology and Metabolism. He has been the past president, Endocrinology Society of India. He is a member, Subject Expert Committee, CDSCO, Government of India. Founder patron, South Asian Federation of Endocrine Societies. President of the Endocrine Society of Bengal. His current research interest into gut microbiome and gestational diabetes mellitus. Pathogenesis of Graves' orbitopathy. Biology of fat in different body compartments. He has more than 194 publications in peer-reviewed journals. Sir, with this, I would like to hand over the podium to you, sir, and you can take the session further. Over to you, sir.
Thank you very much, Dr. Sanket, and a very good evening to all our participants, our audience. And I hope all of us have received, if we wanted to, the first shot of a COVID vaccine. Hope we are better protected and we do not see dwindling of this very important manpower in our society, that of doctors, through affliction from COVID. It's been a painful time, but it's been a learning time as well. And this evening, we shall be talking about diabetes management, type 2 diabetes management, to be precise. And we will talk of the SGLT2 inhibitors broadly, Dapagliflozin specifically. And in this context, there is also a daring trial, I must admit, to use Dapagliflozin in the context of acute COVID and to see if it reduces mortality from respiratory failure, not from heart failure. So, and to take us through this journey, we have none other than Professor Nilanjan Sengupta, who heads the Department of Endocrinology at the NRS Medical College and Hospital. He is also currently the secretary of the Endocrine Society of Bengal. He has many other feathers to his cap. He is, having said all of that, he is a great teacher, a wonderful speaker, and an excellent clinician. So over to you, Professor Nilanjan Sengupta, to take us through the talk, and hopefully that will elicit a significant amount of discussion, questions that Professor Sengupta may be happy to answer later on. So over to you.
Thank you, sir. Thanks for the kind introduction. And I thank McLeod's for organizing this web CME on SGLT2 inhibitors. Let me go to the first slide. Yeah. So we know that all of us have heard about this ominous octet. Previously, the pathophysiology of type 2 diabetes was quite straightforward, an interaction between insulin resistance and beta cell dysfunction. And the therapies targeted to managing type 2 diabetes were also simpler, in a sense that we had only the sulfonylureas and metformin apart from insulin. But now our understanding of the pathophysiology of type 2 diabetes has expanded with the enteroinsular axis coming in, with the renal glucose handling coming in, and fortunately, we have many agents targeting those abnormalities in those systems to the benefit of the recipient. Now, this busy slide, I reassure you, I won't go into the details of it, but this enumerates the important classes of oral antidiabetic agents, to start with the sulfonylureas, which are insulin secretagogues and has been in the market since long, about half a century. We have the meglitinides. Once it was quite popular at the time of it being launched, but I think they have lost their popularity or patronage because of various reasons. Metformin is still growing strong and is recommended by almost all recommending agencies as the agent to start with in drug-naive patients. We have a very controversial class in the thiazolidinediones. The only probably surviving thiazolidinedione is pioglitazone. The usage has come down as compared to what it was a decade before, but still, I would say that is a good class of agents, a handy class of agents. Of course, the dipeptidyl peptidase 4 inhibitors have changed the way that we are treating type 2 diabetes. If you can ask for one agent that gives you a peace of mind or a carefree prescription, it will be the dipeptidyl peptidase 4 inhibitors. We have the GLP-1 receptor agonists too. Most of them are injectable, costly injectables, are more efficacious compared to the DPP-4 inhibitors. Of course, we also would be having semaglutide in the oral preparation to be launched in the latter half of 2021. That will actually make incretin analogs even more patient-friendly. We have also the alpha glucosidase inhibitors, though not very popular or not very strongly recommended in North America or even in Europe, but this is a good agent among Japanese and Indian patients too. So a little bit about the guidelines, the important guidelines as they change the ADA 2020. Now, what is important here is that in the previous guidelines, the presence of atherosclerotic cardiovascular disease or heart failure, that is the cardiovascular comorbidity, was not given much importance to while suggesting choice of the oral antidiabetic agent or insulin or the injectable preparations. But now patients are being classified whether they are having those cardiovascular comorbidities or not. And if they do have, then the choice of agent changes. As I will show you, they're either the SDNT2 inhibitors or the GLP-1 receptor agonists are preferred in comparison to the other agents, like even the DPP-4 inhibitors and definitely sulfonylureas and thiazolidinediones. So that is it. In the ADA EASD update also, if atherosclerotic cardiovascular disease predominates, one should select a GLP-1 receptor agonist or an SGLT2 inhibitor. And if heart failure or chronic kidney disease predominates, then the choice would be an SGLT2 inhibitor if you go by these recommendations. But the point is that if you become too cardiovascular disease centric, at times it becomes difficult to follow these recommendations because these patients may otherwise qualify for use of an SGLT2 inhibitor, but other comorbidities, notably that involving the urogenital tract, may preclude use of an SGLT2 inhibitor. So when actually you are treating a patient who is sitting in front of you, when it comes to the choice of the appropriate oral antidiabetic therapy, one should take a holistic 360-degree view, not only just take into account that the patient is having just heart failure or an atherosclerotic cardiovascular disease or had had a myocardial infarction in the recent past or like that, but whether we can actually use these agents safely. Again, for the GLP-1 receptor agonists, they may be theoretically very appealing, but still now in India, they are costly injectables. And despite the theoretical appeal, many patients would not like to take a costly injectable when there are other alternatives, which are oral alternatives that are available to them. Secondly, nausea and vomiting may be a bothersome side effect, at least in some percentage of patients, that may preclude their use. So this is also, again, the ACC guidelines. I think they are looking more at the risk reduction of atherosclerotic cardiovascular disease. So more or less these are similar. So you can start with an SGLT2 inhibitor. They are preferring empagliflozin because of the studies that empagliflozin had behind it. But again, dapagliflozin also are having important trials, as you will listen shortly. So let's look on the role of SGLT2 inhibitors in glucose homeostasis and its role also is so far as cardiorenal pleiotropic benefits are concerned. You know, kidney is involved in regulation in glucose homeostasis, and the SGLT2, that is sodium glucose transporters. There are two types of SGLT2, SGLT1 and 2, which are expressed in the renal tubules, in the proximal convoluted tubules. SGLT1, SGLT2 predominates, and that helps in reabsorption of glucose from the glomerular filtrate. So this, as I have pointing out, glucose reabsorption occurs predominantly 85% from the proximal tubules and is mediated by SGLT2. A minority is mediated by SGLT1. SGLT1 is predominantly present in the gastrointestinal tract, so much so that if you have a dual SGLT2 and SGLT1 inhibitor like sotagliflozin, that can have a predominant effect on postprandial hyperglycemia. So in diabetic state, in a state of chronic hyperglycemia, when the glomerular filtrate is having a lot of glucose, there occurs upregulation of the sodium glucose transporter 2 in the renal convoluted tubules. And therefore, which helps in glucose reabsorption. If you can block this SGLT2 transporter, then glucose will not be reabsorbed from the glomerular filtrate in the proximal convoluted tubule and will be delivered to the distal convoluted tubule and finally will be passed out with urine, thereby effecting loss of energy and thereby helping in glycemic control. So this is a very simple mechanism of action of SGLT2 inhibitors. these SGLT2, these glucose transporters, help in glucose reabsorption from the proximal convoluted tubules, and their expression is upregulated in a state of hyperglycemia that we see in type 2 diabetes and maybe also in other forms, but they're approved for use in type 2 diabetes at this point of time. And if you can inhibit this transporter, then you can effect glycosuria, whereby there would be energy loss that will be translated into control of hyperglycemia without causing much of hypoglycemia, and as pleiotropic advantages that has been shown to decrease body weight, including deep abdominal adiposity and very many other pleiotropic benefits. So this is again a busy slide showing the potential cardio and nephroprotective effects of SGLT2 inhibition. Then, as I was pointing out, apart from causing glycosuria, thereby causing energy loss, they can cause effect weight loss, which is a very much desirable attribute to an oral anti-diabetic effect. Then alternative fuel metabolism that is promoting ketogenesis can have certain beneficial effects on cardiac contractility, especially to a failing cardiomyocytes. That's why probably we have seen beneficial effects in heart failure. They may have antihypertensive properties, effect uricosuriya, can cause natriuresis by way of the tubular-glomerular feedback. So they can be looked upon as also being a diuretic. So they have dominant diuretic and natriuretic properties, whereby their beneficial effects in heart failure have become manifest. So this slide also actually summarizes whatever I have said. They can take care of the glucotoxicity, and indirectly by way of, though these agents do not have any direct effect on insulin sensitivity, but indirectly by causing weight loss and loss of deep intra-abdominal fat can actually improve insulin sensitivity, and also thereby can have some beneficial effects on non-alcoholic fatty liver disease too, where insulin resistance is one of the important components of pathogenesis of the condition. So I think studies are underway in looking at those very many pleiotropic benefits, including non-alcoholic fatty liver disease and steatohepatitis with SGLT2 inhibitors. So we have a lot many. In India, the first SGLT2 inhibitor to be launched was canagliflozin, followed by dapagliflozin. We had empagliflozin. We also have remogliflozin in the Indian market, and orthogliflozin is yet to be available in India. So let's come to dapagliflozin. The studies behind dapagliflozin are quite impressive and quite numerous. There are more than 35 trials looking at cardiovascular disease, of course, DAPA-HF and DECLARE-TIMI, of which are the most quoted studies, but there are more than 35 trials with cardiovascular disease alone, and we have studies on the renal health too. So that is looks at the glycemic efficacy, HbA1c reduction with as a monotherapy. This slide shows as a monotherapy with other agents. That is to say that dapagliflozin, or for that matter SGLT2 inhibitors, are good at lowering glycated hemoglobin when used alone or as a combination with other agents or insulin, which is why they have become so popular as an oral anti-diabetic agents. So you can see the mean body weight change is around 3 to 4 kilos, which also is a very desirable property. I think only two classes of anti-diabetic agents, notably the incretin analogs and the SGLT2 inhibitors, significantly have been shown to reduce body weight, because diabetes is a major problem with many of the patients, and if any agent that can effect weight loss would always be welcome, except for perhaps the very lean and frail type 2 diabetes patients. Because of the diuretic and natriuretic properties, SGLT2 inhibitors also have a beneficial effect on systolic blood pressure reduction, and this has been shown by many studies, again, with metformin, when used with metformin, or when we use with other agents too. Now, a little bit about the cardiovascular disease outcomes, and this is the most famous study with dapagliflozin in cardiovascular disease, that is the DECLARE TIMI. It evaluated the effect of dapagliflozin compared with placebo on various cardiac outcomes, and it was a randomized double-blind placebo-controlled trial. The study spanned for around 4 years. The endpoints were a composite of CV death, myocardial infarction, and stroke, that is the 3-point MACE. And the important point where it's looked at is a composite of hospitalization for heart failure and cardiovascular death. So I won't go into the details because that would be quite boring, but compared to placebo, when you looked at cardiovascular death or heart failure hospitalization taken together, the dapagliflozin was superior as compared to placebo. But the difference was not that significant when it came to all-cause mortality or major adverse cardiovascular events. So what I presume mainly is that risk reduction has been driven largely by the diuretic and natriuretic properties of dapagliflozin, whereby we got the very impressive data so far as heart failure is concerned. Of course, there are certain real-life studies also. There are two types of studies now we get to look at. One is the real-life registry sort of studies, where the patients are more like our day-to-day patients that we see in our practice, and the formal randomized controlled trials. So in the real-life studies also, this is the CVD real study, and then it's the Nordic subvariant of the CVD real. It's a data registry where these patients were on SGLT2 inhibitor as a contrast to DPP4 inhibitors, and most of the patients were on dapagliflozin, at least in the Nordic arm. And the primary endpoint were again MACE, heart failure, hospitalization, and all-cause mortality. And you see here it was significantly better in the dapagliflozin arm as compared to a DPP4 inhibitor when it came to MACE, all-cause mortality, and definitely with heart failure hospitalization. So a little bit about the CKD outcomes. Again, we have a very interesting study, that is the DAPA-CKD, dapagliflozin in patients with chronic kidney disease. The study was designed to assess whether treatment with dapagliflozin as compared to placebo reduced the risk of renal endpoints. Again, it was a double-blind RCT comparing 10 milligram of dapagliflozin with placebo, patients being followed up for a median of 2.5 years. The primary endpoints were either a composite of, the primary endpoint was a composite of more than 50% decline in EGFR, end-stage kidney disease, and renal or cardiovascular death. And the second, they did a hierarchical analysis. The secondary outcomes were a composite of sustained EGFR decline greater than equal to 50%, ESKD or renal death, followed by cardiovascular death or hospitalization for heart failure, and followed by all-cause mortality. So among the patients with kidney disease, regardless of presence or absence of diabetes, there was a decreased risk in the decrease in EGFR, end-stage kidney disease, or renal death or cardiovascular death. That all these parameters taken together was significantly lower in the dapagliflozin arm in the primary composite outcome as compared to placebo. So without going into the details, this can be interpreted that dapagliflozin as an SGLT2 inhibitor has a beneficial effect so far as renal protection is concerned. And the most interesting part of it was the lowering in albuminuria. And this is one study, the DELIGHT study, which actually looked at the albumin excretion in between a placebo group, a dapagliflozin group, and a dapagliflozin and saxagliptin group. So that is an SGLT2 inhibitor with a DPP4 inhibitor. So the main outcome was that dapagliflozin with or without saxagliptin given with SE inhibitor or ARB, which is probably the standard of care, is a potentially attractive option to retard the progression of kidney disease in patients with type 2 diabetes. So this again is a busy slide comparing empiric outcome, Canvas, Declare, TIMI, and the VERTIS-CV. VERTIS-CV, the slide shows ongoing, but it has really been published, and where artegliflozin did not come out to be superior as compared to placebo when it came to cardiovascular protection, it came out to be non-inferior. Whereas in empiric outcome, it by and large came out to be superior as compared to placebo. And so also maybe in the Canvas and Declare TIMI, in the when you take hospitalization, heart failure hospitalization and cardiovascular death taken together, that was significantly better as compared to placebo. In the empiric outcome, the 3-point MACE was also significant. Of course, it is probably not very fair to compare all those studies because the study population has differed between study to study. For example, in the empiric outcome as well as in the VERTIS-CV, 99% of the patients had established cardiovascular disease, whereas in the Canvas program, around 33% patients had multiple risk factors, as well as in the Declare TIMI, around 60% patients had multiple risk factors and around 40% had established cardiovascular disease. So that was a difference in the composition of the patients. So I won't go into the details, you all know about it, but I think whereas broadly the studies point to the same thing of prevention of heart failure with any of the SGLT2 inhibitors, but there are minor differences in the study results, and this is because of the differences in the study population, in the differences in the study design, and may or may not be certain inherent differences in the molecule. That, of course, is a very difficult question to answer. Some may argue that these benefits are molecule specific. Some may say, though these are basically class effects, but because of the study design, because of the study composition, and because of differences in the way we analyze the studies have been analyzed and interpreted, we are getting a little bit different results. But then these are interesting large studies with SGLT2 inhibitors. This you all know. The dosage, I think the standard dose of dapagliflozin is 10 milligram, canagliflozin 100 to 300 milligram once daily. Empagliflozin, we have two dosages, but I doubt whether going from 110 to 25, we really do get any significantly more glycemic benefits. Remogliflozin, of course, in India, we had been using 100 milligram twice daily rather than 200 milligram once daily. But I think with the availability of generic dapagliflozin, now that has the convenience of once daily dosing, whereas in remogliflozin in full dosage has to be given in a twice daily regimen. And now I think the generic dapagliflozin are less expensive than remogliflozin 100 milligram twice daily, and remogliflozin doesn't have much studies to back it as we have with dapagliflozin, notably the DAPA, CKD, or Declare-TIMI. So I think prescriptions in India at least will shift more from remogliflozin towards when the cost of treatment is an issue. When the cost of treatment is not an issue, probably one can choose between canagliflozin, dapagliflozin, and innovator dapagliflozin and empagliflozin. But when the cost of treatment is an issue, we have to choose between a generic dapagliflozin and remogliflozin because of the once daily convenience, because of the impressive data supporting dapagliflozin and the cost of therapy. I think dapagliflozin will be increasingly preferred over remogliflozin in India. So I think this is the last slide. The future is bright. Yes, of course, the indications of SGLT2 inhibitors are expanding. Now dapagliflozin is approved for use in heart failure with reduced ejection fraction in a patient who is not having diabetes or hyperglycemia, and is used quite often by the cardiologists, apart from, of course, their use in the management of hyperglycemia. So, and previously, an eGFR cutoff was 45 or even 60 was taken for use of any SGLT2 inhibitor. Now, at least with canagliflozin, we can use an SGLT2 inhibitor up to eGFR of 30. That has been an advantage. And following the trial with empagliflozin, which have used empagliflozin up to 25 mils per minute eGFR, the usage of SGLT2 inhibitors as a class in presence of chronic kidney disease will also increase as the usage will increase in heart failure without diabetes. And maybe also trials are going on for the use of these agents in heart failure with preserved ejection fraction. And as I have told, studies are underway in non-alcoholic fatty liver disease, and even I see one study, dapagliflozin in respiratory failure patients with COVID-19 in the COVID-19 era. If that comes out to be positive, that also would be a great game changer. But still, I think in patients having COVID and especially COVID pneumonia, we are stopping the oral agents especially agents like SDLT2 inhibitors for the time being, and preferring the patient to be put on insulin, and that too a multiple subcutaneous injection regimen for the ease of glycemic control. So with this, I actually come to the end of the talk. Dapagliflozin, or for that matter, SGLT2 inhibitors, are new agents but have proved to be very effective high anti-hyperglycemic agents, in that they effectively reduce hyperglycemia independent of beta cell function, can be used anytime in the timeline of a patient of type 2 diabetes, do not cause hypoglycemia on their own, do not cause weight gain. However, there are certain side effects, notably genital mycotic infections, urinary tract infections that can occur in certain patients, and volume depletion, dyselectrolytemia, euglycemic diabetic ketoacidosis, so much so that no matter how good these agents are, before prescribing, one should have a quick check on the contraindications. If those contraindications exist in a particular patient, then we should be wary of using the SGLT2 inhibitors. Otherwise, these are excellent, promising agents with promising pleiotropic extraglycemic benefits, along with being very good anti-hyperglycemic agents. Thank you.
Thank you very much, Professor Nilanjan Sengupta. That was an excellent talk overview of management of type 2 diabetes overall, but more focused on the use of SGLT2 inhibitors, and letting us understand really the usage of these agents even beyond glucose control. And as of now, the established areas are in the context of heart failure with reduced ejection fraction, and also chronic kidney disease, and either with or without diabetes. Now, I'll come to questions in the chat box, but before that, can I ask you, it's commonly or popularly used in people with who are obese because of its additional property of causing some weight loss. So can it be used in normal weight type 2 diabetes as well?
Yes, sir, thank you. I think they can be used in normal weight type 2 diabetes. But again, you have to justify why you are using it. If you want to use it for glycemic control, not control with other agents, we can always add an SGLT2 inhibitor, even if the body weight is, the BMI is not high, and also maybe for pleiotropic benefits. But in the extremely frail elderly, I would be a little bit hesitant in using an SGLT2 inhibitor. Otherwise, even in so-called lean or non-overweight type 2 diabetes, they can be used.
Yeah, and also the weight loss is partly dependent upon the baseline body weight. So if you are more obese, you are likely to lose more weight. And if you're non-obese, you're not likely to lose significant amount of weight. The other issue is the DCGI approvals. So what are the current, in our country, we are not talking of what ACE recommends or ADA recommends, which are important guidelines, but what does our country, our DCGI, or currently rephrased as CDESCO, Center for Drug Standards Control Organization. So what are the indications for which dapagliflozin is approved?
I think in India, dapagliflozin is, of course, approved for managing hyperglycemia of type 2 diabetes, that everybody knows. And if I'm not mistaken, for heart failure with reduced ejection fraction. These are the only two things. I'm not sure whether there's been any phrase to including renoprotection. The studies have showed, but I think there is no position statement that for renoprotection this can be used.
At this point of time, I am given to understand at least AstraZeneca only very recently, in the last 1 or 2 days, I understand, they claim that they have received DCGI approval for use in CKD up to stage 3, CKD stage 3, which means EGFR up to 30 milliliter.
Yeah.
But
that is the approval. I think it was 45 previously, now it's 30. But is there anything, even I'm asking you, is there anything that it can be used for renal protection that way?
Yeah. So that's the use for use in CKD. That's my understanding.
Right.
But if we are using up to EGFR 30, is that for kidney protection only, or is it also for improving glucose control? Do you think that glucose lowering efficacy will still pertain at low EGFRs?
I think theoretically no, but inadvertently I have used SGLT2 inhibitors. Maybe the patient came up with an old creatinine, now comes with a new creatinine, and calculating the EGFR comes out to be, say, 28 or 29. But even then, SGLT2 inhibitors tend to work as anti-hyperglycemic agents. That's my 1 or 2 personal experience. But otherwise, I think if the EGF, with the dwindling EGFR, the glycosuric effect theoretically should not be as much as it would have been with an EGFR of, say, 50 plus.
Right. So we have a question from Dr. Sanjay Sengupta. I do not know exactly what he means, but he most likely wants to know whether we can go for 3 drug combinations: glimepiride, metformin, and iron stand and SGLT2 inhibitor. We do not have this combination yet, but yeah, I know Professor Sengupta is not a fan of these fixed dose combinations. But what are your views, Dr. Sanjay Sengupta?
Yeah, I think we can use three drugs logically, rationally, if there are no other problems of using it, because metformin, the mechanism of action, has its been acting via AMPK. Glimepiride means it's an insulin secretagogue, and SGLT2 inhibitor will improve the glycosuria and thus control the hyperglycemia. So I think there is no reason for glycemic control if the patient is uncontrolled with metformin and a sulfonylurea. You can select an SGLT2 inhibitor. And again, as was pointing out, if at this point of time, if the patient is obese or putting on weight with glimepiride, an SGLT2 inhibitor would be a rather good choice.
Right. Dr. Manjur Hussain wants to know whether he could use it in type 1 diabetes along with insulin.
That's an interesting question. I think Dapagliflozin has been tried in type 1 diabetes along with insulin, of course, but it has not been formally approved by the US FDA. I think it's some countries like in Japan and some European Union states, they are using an SGLT2 inhibitor with in insulin in type 1 diabetes, mainly if it is a combined SGLT2 and SGLT1 inhibitor that will take care of the postprandial glycemic excursions even better by preventing glucose absorption from the intestine, in addition to the renal glycosuria that they effect. But I think in India, it is still not approved.
Yes, and I don't think there are many more questions. So I think we can sort of wind up gradually. And Professor Sengupta, you can, of course, put in if you have any additional points to make. This group of agents, of course, have come a long way since the first agent came up and really proved their worth beyond glucose control, and so providing important organ protection, primarily the heart and the kidney that we know of now. But there are studies, as Professor Sengupta has also alluded to see if they also provide protection to the liver in terms of amelioration of non-alcoholic fatty liver disease. We still, of course, these are still relatively new compared to metformin or sulfonylurea, but still we have had several years of with these agents, at least what, 5 or 6 years? When was the first agent approved? About 2000?
Can I be
2009, sir.
Sorry?
2008, 2009 was empagliflozin.
No, for in India?
It's 2013, if I'm not. 2015,
yeah,
sir.
But still, I think we are continuing to learn. For example, Professor Sengupta did say that many of its effects on heart failure are because of its diuretic or natriuretic action. But at the same time, we do know that the thiazide diuretics have not been shown to reduce mortality, but these agents do so. So there's something more to that. And he's, of course, talked of various substrate hypotheses and all these. But these are very important agents. And because they're orally effective, they are therefore attractive. At the same time, they were a lot more costly. They are still costly, the originator brands. But in India, we are fortunate that we now have these very good effective agents now available at a cheaper price. And so I think we can now offer the services of these molecules to a wider group of agents. Now, in the meanwhile, there have been a few more questions, if Professor Nilanjan Sengupta would not mind answering. Dr. Subroto Banerjee, may I try again after complete treatment of UTI caused due to dapagliflozin? I mean, it may not be due to dapagliflozin. So essentially the question is, someone had a UTI while on an SGLT2 inhibitor treated, and shall we resume dapagliflozin?
This is an interesting practical question. If there's been a single episode of UTI, and if you do not find any correctable anatomic abnormality in the urogenital tract, then you can resume the SGLT2 inhibitor after you have successfully treated the UTI. But what I do in my practice, if such an episode occurs, I try to find out, even in consultation with my urologist colleague, whether there are any major anatomic or other physiologic abnormalities of the urogenital tract, like a bladder neck obstruction, neuropathic bladder, or a urolithiasis or something like that, or more commonly, an untreated prostatic hyperplasia. Now, if that is not taken care of, and again you give an SGLT2 inhibitor, that may be a problem. Otherwise, just a single episode of UTI, not a urosepsis, which has been easily controlled, we can think of resuming dapagliflozin safely.
Right. And Dr. Obibroto De, can we use it in IFG or IGT?
So conceptually, I think this is an attractive area where we can use, because they may have some benefits on the blood glucose. They may have some important benefits on body fat composition, thereby improving insulin sensitivity. But mind it, they are not yet approved anywhere for use in pre-diabetic states. I think we need further studies, and if the studies are encouraging the ultimate results, then they may be used. But I think it is a bit premature now to use them outside any experimental protocol.
Thank you very much. I think this was a wonderful talk and a very good discussion. And I'm really thankful to Professor Sengupta for sparing his Saturday evening to spread across the message of this new class of agents, and especially about dapagliflozin, which now we can offer to a wider group of our patients because of better cost that is available. And of course, to our participants also for putting up interesting questions and interesting clinical situations to discuss about. And I would like to hand over to MacLeods, of course, thanking them for providing this platform. Over to Dr. Sanket Newali.
Thank you, sir, for the excellent moderation. Thank you, Dr. Sengupta, sir, for the wonderful and enlightening session. I'm sure the listeners would have gained deep insights in managing patient better using the learnings from your session, sir. We at McLeod's would like to honor your vast experience and your kind heart to share the same on such a platform for benefit of all the current and the future listeners. And a special thanks to a large audience today. So we have more than 100 attendees today listening to our session. I want to take this opportunity to thank each and every participant attendee who has taken time out from his busy schedule and have respected our invitation to be a part of this scientific feast and actively participated by asking questions, sir. I, Dr. Sanket Nevale, representing medical team at McLeod's Pharmaceuticals, on behalf of the marketing and the sales team, I would like to thank you for supporting us in this scientific endeavor. And I wish you a great evening ahead, sir. Thank you.
Thank you. Good night.
Good night, sir.
Good night.
Thank you, sir.